Hello, and welcome to Hard Conversations. This is a podcast about male sexuality, intimacy, and sex positivity, where we unpack the taboo topic of erectile issues in a safe, non-judgmental space. And now, here's your host, sex therapist, Timothy Norton.
Hello, and welcome to Hard Conversations. Really excited for my next guest, Doug Braun Harvey, a licensed marriage and family therapist, certified sex therapy supervisor, certified sex therapist, sexual health author, and trainer. He teaches and trains nationally and internationally on sexual health principles within drug and alcohol treatment, group psychotherapy, HIV prevention and treatment, and child maltreatment. Since 1993, he has been developing and implementing a sexual health-based treatment approach for men with out-of-control sexual behavior. His book, Treating Out-of-Control Sexual Behavior, Rethinking Sex Addiction, was written with co-author Michael Vigorito and published in 2015. A couple years before that, Doug Braun Harvey and Al Killen Harvey co-founded the Harvey Institute, an international education, training, consulting, and supervision service for improving healthcare through integration of sexual health. He is an adjunct assistant professor in the Center for Human Sexuality Studies at Widener University and faculty for the University of Michigan Certificate Program in Human Sexuality. He also wrote Sexual Health and Recovery, Professional Counselor's Manual, and Sexual Health and Drug and Alcohol Treatment, Group Facilitators Manual. Welcome to the show, Doug.
Thank you. It's good to be here.
Yeah, so excited for this interview. I worked in, we'll just jump right into it. I worked at a clinic that branded itself as a sex addiction clinic for a few years. And I spent so much time in that world. And then when I got into ASECT, I was, learning your model, honestly, learning the out of control sexual behavior model and working with that population for so long that I kind of got burned out on it. But I've had a bunch of requests from people who want to hear, how does this impact erections and sexuality? And it's such a germane issue to male sex in 2019. So I'm just really excited for this interview, and thank you so much for appearing.
Tim, it's great to hear about your background. I don't often do podcasts or interviews of this kind of nature with people who've had their own professional direct work in providing sex addiction treatment and then, moving into the sexual health model. So this is a rare opportunity. Thank you for letting me know that. I didn't know that.
Okay. Yeah. No, fantastic. So let's jump right into it. You developed a model for the treatment of out of control sexual behavior. You wrote a book.
Michael Vigorito and I co-wrote a book.
Yes. The two of you. A really important book in my world and in the world of sex therapy and sex therapy treatment. So can you just tell us a bit about that? Well,
I think it would start with why there needed to be a book written like this, and that this human behavior, which I'm going to call from a general perspective for this interview, sexual dysregulation. For whatever reason, somebody's not feeling like they're regulating their sexual behavior very well. And there has been a significant controversy since the 80s about what exactly we call this. And for the most part, everybody has been trying to figure out what to call this, and I'm going to emphasize this word, disease. The idea is that this human behavior is some sort of a disease, a psychiatric disorder, addictive disorder. This has been the story since the 80s, that's how people have been wanting to understand it. So is it compulsive sexual behavior? Is it a sexual addiction? Is it a hypersexual disorder? Is it impulsive compulsive sexual behavior disorder? I mean, these have all been sort of bandied about, but the one thing they have in common is they've all viewed this behavior as a form of mental illness, a kind of disorder. And what people have been, really kind of debating is what what kind of disorder it is, but they've all believed it's a disorder. The one thing that stands out in the sexual health model that Michael and I have developed with out of control sexual behavior is that we do not believe this human behavior is a mental illness or a psychiatric disorder or an addictive disorder. That is the most significant kind of cleave here that we're going to be talking about today. Is that everything we're talking about in our model is we're not saying that somebody has a disorder. And that's really why this book was written, and that's why Michael and I spent so much time elucidating a model that I eventually, grew out of my work. I started my first group for men in out of control sexual behavior. I didn't even use that term then. The term out of control sexual behavior didn't come about until a journal article by John Bancroft and Vuketinovich in 2004, where they recommended that until we have a better idea of this behavior, we call it out of control sexual behavior. Before that, I called it a variety of things, but I never believed in the sex addiction model. So since 93, I've been providing outpatient group and individual therapy without a disease model. And having to kind of figure out, well, what is this? And so eventually Michael and I really put together this model and wrote this book. So I think that's the most important thing. We're not talking about somebody who has a disease. And that's why the book was written. It's a sexual health model rather than a disease model.
Right, absolutely. And I remember when I was first learning about the sex addiction model, was one thing that I really didn't like about it was it kind of felt like we threw the baby out with the bathwater. We threw out everything. If we had a client who came in, nobody was asking, well, is this client depressed, bipolar, an anxiety disorder? Like that suddenly became secondary, and a lot of personality disorders, a lot of narcissism, and borderline, and that was such a distant thing to talk about. But it's really different to work with bipolar than it is, just depression without mania or just anxiety, and the clients would present much differently. And there was just so many things that were getting lost. And I like not thinking of this as a disorder. It's an aspect of something else that's going on, wouldn't you say? Or it's a coping.
Well, it's a problem. Out of control sexual behavior is a problem, but many people can have problems and also have disorders that are happening at the same time, or affect each other, interact together. What you seem to be commenting on is that, at least in your experience in a sex addiction treatment program, the psychiatric conditions that might be present were not given as much prominence in the overall case conceptualization that it sounds like you thought they needed to have. And it seemed like a kind of an omission of priorities that this wasn't somehow really looked at in a more critically thought out way, that the sex addiction model was really the model in which their behavior was viewed. That this is what can happen with disease conceptualizations or disorder conceptualizations. It all has to every patient is supposed to fit within that sort of, kind of narrative that's been designed around the particular disease. And it sounds like you saw that in your experience.
I did. And if somebody, I remember a couple times where somebody might present with suicidality, and I'd have to chime in and say, look, we're not that kind of clinic. We don't treat highly suicidal people here. We're not, that's a whole system. There's a whole way of handling that. And we were dealing more with, long-term married people in an affluent neighborhood, and the guy had acted out for years at a time, and there's a sudden affair that was revealed, and which is tough work in its own right, but it's very different than somebody who's actively suicidal. And I'm just saying, like, we have to work with this first, and we probably are going to have to refer this person out to somebody who's accustomed to dealing with suicidality on a regular basis. And those kinds of things. It's tricky in those settings, and I've seen that in a couple of different sex addiction focused centers.
Yeah. You also used a phrase that I really like to highlight. You used the phrase acting out. in your sentence. And
I wondered about that. Yeah.
You may have read my work enough, and Michael's and I work enough to know that we emphasize language, and we think language is very important. And I think the language of acting out, that phrase is really also comes from disease models and mental illness models, that this sort of idea that a behavior is a representational of, some more deeply, a kind of underlying psychological or psychiatric conditions. And so that's just sort of acting out an unaddressed mental illness. And I really take umbrage at the use of the word acting out when we're dealing with out of control sexual behavior. I find it a kind of, when I train therapists, I talk about how that you're really avoiding detailed and specific language about a person's sexual life. So whenever I'm working with a therapist or in a case conceptualization with somebody and they say, well, so-and-so acted out, I didn't want to interrupt you, it's your podcast, but I would normally say, wait, let's stop right there. What do you mean by acting out? I don't know what that word means. And oftentimes a clinician or a therapist or somebody who's talking about, or even a client says acting out. Well, what do you mean? What do you want me to know about you that you're telling me when you say acting out? And let me give you an idea. What are some of the common stories some people say when they say acting out? One of the most common is, I'm not keeping my relationship agreements. I've agreed to a certain kind of boundaries or certain agreements of how we're going to conduct our sexual life in this relationship. And I'm not doing that. I'm not keeping those agreements. And I have unilaterally changed the agreement. And I've not told the person I have the agreement with that I've unilaterally changed the agreement. Now, that's a lot to say. So what people will just say, they'll say they're acting out, because who wants to say all that? That's painful. That's taking a lot of responsibility for decisions that injure and hurt people and exploit people. These are hard things to say. So acting out is often a shortcut way for people to avoid saying detailed and specific descriptions of their behaviors that are painful and difficult to acknowledge and be accountable for.
Yeah, that is a painful sentence. I like how you said that too. I unilaterally have changed our relationship agreement.
And not told you.
Yeah, and not told you about
And here's the exploitive part. I'm going to keep acting like I have kept the agreement.
Yeah.
Now, I call that, failure to keep our sexual health relationship agreements is one of the most common, behaviors as to why somebody says their behavior is sexually out of control.
What would you say is the most typical, or what did you just stop doing private practice work?
I'm actually in December, I will be ending all of my work as a psychotherapist after 40 years of mental health work. I ended my individual psychotherapy work a year ago, and I've been doing my groups now for 27 years, but I'll be ending my outpatient group leader work the end of December. And my work now is about generativity, training and teaching other people, sort of returning all the knowledge I've been given and passing it on and letting other people do more with the knowledge we have, and writing books. So I'm going to be teaching, training, writing books, training other therapists in how to work with sexual health and OCSB. But I'm not going to be providing direct client services anymore in actually 5 weeks.
Oh, 5 weeks. Wow. Okay. Well,
December 17th is my last day.
All right. And I'd want to save this for the end of the interview, but in case we get so mired in this conversation, thank you for the work that you've done. And that's, you've made an incredible and really important contribution to the field.
Thank you.
Yeah. So in the individual work and group work that you have done in these last 40 years, and once you kind of, developed a reputation as the OCSB guy, what would be the more a typical 2 or 3 different case presentations that would come through your doors? Yeah,
I think we've already covered one of them. Somebody's in a coupled relationship. They have agreements as to what their boundaries are within their relationship agreement. and I've only worked with men. This is the OCSB model is really specifically developed for men of all sexual orientations, and I'm going to say cisgendered men. We've not had a trans male client who's presented for therapy. So cisgendered men of all sexual orientations is really what we're speaking of here. And adults, 18 or older. The youngest client I ever had was 23. The oldest was 78. So, quite a wide age range. And what we're really speaking of here is some people will just not keep their relationship agreement. That's very common. Another common one is their relationship with sexual imagery. Oftentimes couples or individuals themselves have not figured out what is a relationship with sexual imagery that they can feel good about, that they feel pleased with, that is pleasurable, and is aligned with their values, and is something that they can speak openly about to new partners or to their current partner. Masturbation and the solo sex life, using imagery for arousal or desire or orgasm or increased excitement or access to an unconventional turn on that you may not be experiencing in person, but is very arousing and pleasurable to look at. These are all reasons people look at sexual imagery for their solo sex life or their partnered sex life. And this is a very common conflict, is the whole relationship with masturbation, solo sex, and use of sexual imagery. And the last one, I would say, I'm going to put into the category that Michael Vigorito and I speak about in our book, and that's an erotic conflict. That somebody has a turn on, a sexual interest, a fetish, a unconventional kind of turn on, something that might be stigmatized or judged if it were to be known that this really turns me on, or I need this particular thing in order to have an orgasm. People have a lot of conflicts about these unconventional turn-ons. They may have hidden them, keep them a secret. And I'll mention here one other aspect of the OCSB model. We only work with consensual sexual behavior. So if I'm talking about an erotic conflict and somebody has minor attractions, or somebody is exhibitionistic or voyeuristic or frauderish, and is, in other words, they, in order to have this turn on, they have to non-consensually engage with another person. That person hasn't agreed to be part of this. That's non-consent. And this model is not a non-consensual model. So the three would be not keeping agreements, one's relationship with sexual imagery and solo sex, and having an unconventional or unresolved conflict about how one gets aroused erotically in a very kind of unusual way.
Okay, wonderful. So let's unpack those. With not keeping the relationship agreement, what would the spectrum look like? So the guy who had one long-term affair, one short-term affair, what would be on the other end of that spectrum?
Well, I tend not to use the word affair. So here's what I would say. A guy maybe had a sexual relationship with somebody else, and it was not in the agreement of the relationship. The key factor there is, did they fall in love with that person or not? And if, I think we have to reserve affairs for the language of falling in love, that somebody actually not only broke the monogamy agreement of the relationship, they had sex with somebody other than their partner, but they also broke the emotional monogamy relationship agreement, which is, you're not going to fall in love with somebody else other than me. Those are two different agreements in relationships that often get merged as if they're one and the same thing. So I think the bigger issue is, if they're having sex outside of their relational agreement, are they falling in love or not? That's a big issue right there. How frequently or how often are they having sex with other partners that are not within the agreement? How frequently it is, and more importantly, what are the consequences? Are people losing their job? Are they going to lose the ability to raise their children? Are they going to have a divorce? Are they going to, have a high conflict divorce? Are they going to possibly maybe have to no longer be part of their religious community? There are just so many consequences that people get concerned about, and the amount of shame and embarrassment and humiliation that might bring to them. So I think what really separates the spectrum of that first one, the relationship agreements, is not so much the behavior they're engaged in, it's what are the consequences? How severe are the consequences? That's usually what gets people to come in for help, is they've experienced a terrible consequence, or they are really scared a terrible consequence is going to happen. And it's so interesting. For one person, the terrible consequence might be my partner will find out. For the other person, the terrible consequences isn't that the partner will find out, it's that I might not get to raise my children in an intact family. And they're really not concerned about injuring their partner. I mean, it's hard for therapists to hear this, but they may not really care that their partner is that injured. They think they're going to get away with it. They just don't want to be raising their kids in a divorced family. And that's why that's what they're worried about. So sometimes we have to be prepared to hear a consequence from a client that in our moral system, we're going, oh man, those are crummy morals. But that's their conflict.
Right. No, that's a really good point. What I was thinking about with regard to the other end of that spectrum is in the media, when we think of this idea of a sex addict, there are stories of, somebody who's gone to multiple sex workers and on dating apps while married and the partner hasn't agreed to that, and is going to strip clubs all the time. And would your clinic or your treatment facilities, would you see that kind of presentation as well?
Absolutely. Any of these sexual activities might be part of what's happening. I think what's different in some of the particularly sex addiction models, notice how as you describe the more severity of the behavior, your focus was on the sex acts that they were engaged in, and I think in particular, many people will see the severity be about how judged those sex behaviors are, how much they're stigmatized, how much they might be morally disapproved of, how much they might be seen, in a negative light. So I think in some models, the focus of severity is actually more on how judged the behavior is, the sexual behavior. Our model focuses on consequences, not the sexual behavior itself. Any of these sexual behaviors could have these consequences, and some may not. For example, we have men in our treatment program who it's on their sexual health plan that they're single and they like to have erotic feelings in their body, and they might go to let's say a place where people undress and are nude for entertainment, and that's part of their pleasure in their life. And they're sitting in a group with another person with that exact same activity is what's torn their life apart and destroyed it. So it's the consequences rather than the judgment of the sex act itself that it really differentiates the sexual health model from some of the other models.
Okay. And that puts it in really good perspective for someone like me and, in terms of how to approach a case. But I'm also thinking about the partner, who just might get really overwhelmed by, oh my God, you did all of those things. And you're saying at the end of the day, really the consequences are going to stand out. But I've met those partners who want to just who want to pathologize it, who want to make it a medical condition, and who want to send this person somewhere and say, fix this. And nobody could do all of those things if they were, quote unquote, normal. But
yeah, I think, one of the things I've learned over the years, it's a crisis for somebody to kind of question, who am I? What does this mean about me if I love somebody like you? And now I know things about you that I can't unknow. And what do I do with this? How do I understand how I feel about you? What does this mean about how our relationship has been over all these years? These are enormously, and I don't mean to over dramatize this, but these are existential crises in a relationship. And these are crises that happen over the course of many relationships. It may not be about not keeping a sexual agreement and exploiting a partner. But I think what you're describing most importantly that's hurtful is, how do I reconcile somebody saying they may have loved me or do love me, and they've also exploited me? This is a very difficult thing for people to understand. And it's very painful. And so that sentence is so difficult to understand, but it's appealing to see it as a disease. There's something soothing about, there's something hopeful about seeing it as a disease, rather than we have to talk about the fact that you have exploited me and I have been exploited by you. Where do we have conversations like that?
And would you use the word traumatizing?
The client needs to use that word. We have to assess it. I think we move a little fast if we put that narrative on that experience as a generalized story for clients. You know, we know from the child sexual abuse field, we know people who've engaged in who've been the target of non-consensual sex as minors, that some people that's an enormously, terribly traumatizing experience. And for other people, it is not a traumatizing experience. But they've had the same human experience. And I'm very concerned about models that impose those narratives of trauma without a good assessment of trauma. You know, what I think is the word that I hear missing too often is hurt. This is what some people look like when they've been terribly hurt, or are in shock, or are, you know, again, existentially, they're completely disoriented.
Right.
Those are real-time experiences. For some people, those experiences may activate historical trauma. And this experience may actually maybe be a trauma for them. It may be the most traumatic thing that's ever happened to them in their lives. But I think the dilemma is we place this narrative in a general way to describe the experience of two people in a relationship where exploitation has been a solution to a problem and it's injured somebody deeply.
Yeah, I really appreciate you saying that regarding the assessment of trauma. And so maybe for the listeners who don't know how to assess for trauma, could you highlight a couple of trauma symptoms that you'd like to see before actually, using that word?
Well, I can speak to this from many years of working with men with OCSB who have their own trauma histories, right? I'm not going to speak to the partners because I've not treated the partners, but, trauma is when you have intrusive thoughts about past experiences in your current everyday life, that something is happening in your environment, something's happening in your emotional state, something's happening in your relational experience, where all of a sudden your body biophysiologically is having an experience that is in some way a component of some historical event that was highly traumatic. Somebody might have a body memory that had to do when they were, physically assaulted and beaten on a street. And they're sitting in a group talking about something, and all of a sudden they're flooded with the memory of that, and their body's actually having sensations that are similar to that experience, and it's terrifying for them because they don't know how to understand this. How can I be feeling this sitting here? And if they don't know that that's a trauma recall experience, they're going to think something in the room is highly dangerous and misattribute what's going on and get terrified that somehow they're in danger.
Yeah. Okay, perfect. And that's such an important point. I mean, not that, I don't want to get into semantics when, people use words differently than clinicians do, but it can be hyperpathologizing if somebody's not dissociating or having flashbacks or nightmares and things like that. Like you said, there was a ton of hurt.
Yes. Pain. They're having pain. They're remembering something painful. When we remember something painful, that's not trauma. That's remembering pain.
Yeah.
And I don't mean to minimize people who experience trauma, but I also don't want to dilute the intensity of people who do experience trauma by overgeneralizing that word to people who are in a different spectrum of pain than trauma.
Yeah. And so just to clarify, before I want to get into the imagery stuff, but I also just want this to be clear to the listeners that, everything that you talked about with the man who's not keeping his relationship agreement. It's regardless of the details of that, regardless even of the consequences of that, there's not, I don't want to think that there's somebody out here who's saying, well, that doesn't really apply to me. No, I'm just an addict. Like, you're talking about this in an all-encompassing way, that there's not some level of pathology that somebody gets to where you're calling them a sex addict ever.
Me?
Yeah.
Well, we don't have any science yet that establishes a kind of clear, agreed upon consensus among many different people who understand this behavior. We have no agreement as to when this might be actually a disease or a disorder. I mean, there are people who believe it is. There are people who treat it as it's a disorder, but we still have no agreement as a mental health field to say, here's the standards, here's where you cross a threshold, here's where you've now really in the range of having a disease. Each attempt to do that in the psychiatric manual has been now eventually completely rejected. It's just been rejected because the science isn't there. Now we have the International Diagnostic Manual, which is called the ICD. It's the International Classification of Diseases. It's actually what every other country in the world uses to classify their diseases, except the United States for their psychiatric diseases. And that has just now come out with an actual disease idea of compulsive sexual behavior, is what they call it, compulsive sexual behavior. And they think it's a part of people who have impulse control problems. There's a psychiatric disorder classification called impulse control disorders. And they think some people might have compulsive sexual behavior who have difficulty controlling their impulses. The difficulty is reflected in their sexual behavior patterns. Now, this is an idea. It's in the classification. We don't have studies. We don't have anything to actually say, yep, we've now studied this and we've determined there is a condition called compulsive sexual behavior. But the reason they included it in the classification was, let's check it out. Let's call it what it is, describe what we think it is, and now let's do some research to see if there's anything to support it. So that's the closest thing we have.
Okay. And the distinctions, I suppose, have to do with, when we're talking about drug addiction, we're talking about withdrawal, and we're talking about tolerance, and we're talking about consequences and all that good stuff. So, and when you say the research hasn't been great on it's really hard for them to establish an actual physical withdrawal like you would get from a heroin.
Well, the sex addiction field has moved away from tolerance and withdrawal as their defining characteristic for the disease. They've really put much more emphasis, as well as many other, addictive disorders have, on the brain component of addictive disorder, and looking at changes in brain functioning and neurobiological changes in the brain. We've looked at this with drugs, of course, and the changes in brain with different drugs you put in your body, how it affects the brain. But this is a very important area of study. And those brain studies, neurobiological studies, neuropsychiatric and psychological studies around how the brain functions in the state of different aspects of sexual arousal and changes in the way the brain functions in sexual arousal based on a kind of addictive process developing, is really what the sex addiction field has invested a great deal in. Now, the dilemma with most of the studies and this is a perspective I find credible as a critique, is most of the studies that have been done, the fMRI and the brain imaging studies on how the brain functions in states of sexual arousal, have been done primarily by people looking at sexual imagery on a computer, these sorts of situations, and then measuring the brains of people who identify as sex addicts and measuring the brains of people who don't identify as sex addicts, and see if their brains are wired differently based on the fact that they've now entered into an addictive process. That's the idea. And they have seen some differences based on where the brains light up. However, none of these studies have been done while people are having sex. Right? So the dilemma with all of these studies is it's based on how the brain functions while having sexual imagery or sexual, activity being activated by viewing. but we know the brain functions enormously differently while we're having sex. We don't have any measurements of what somebody who's been diagnosed with sex addiction, what their brain looks like while they're having sex.
Yeah. No, I had Dr. Nicole Prouse on this show some months ago, and she was very eloquent about that point. And speaking from experience, because she actually does do research with people.
Well, it's Dr. Prouse's research that I really rely on to make that statement. And I was going to say her name in a minute, so thank you for saying it for me. Because it is Dr. Prouse who's taught me through her studies that, we have to really look at the science. And I'll just say one more thing about fMRI studies. fMRI studies are where you look at the brain and where it lights up in these kind of the technology. Rory Reed, who's a brain neuropsych researcher as well, told me this story where they were doing some fMRI studies on fish, and they were seeing if fish's brains lit up differently under these fMRI machines if they showed the fish different colors. So they would show them red or blue and see if the brains lit up differently. And they did. But here's the most important thing about that study. All of the fish in the study were dead.
Oh my God.
Now, think about that. All of the fish were dead, but they did get reactions on the machine. What this teaches us is the machines are not infallible. We think when we do research with machines that the machine is so infallible, the only reason for any data to be of significance is the human subject that's being measured. We have to remind ourselves these machines have their own fallibility. And so it's an interaction of the technology limitation and the limitations of the scientific design that I think lead to some of these conclusions that I think are inaccurate.
Yeah. And I don't know if I've ever soapboxed about this on this podcast. I could probably fill an hour with the very large conclusions that a lot of people draw from those fMRI studies, and they're very compelling. And and I would love it if the sex addiction camp would speak in those terms. Like, there's some compelling information that we found where there's some similarities between these two brains. We're still going to research it. I'd like to see 1,000 subjects in just one of these studies. I'd like to see, like you're saying, people while they're having sex. That's really hard research to get funded, by the way.
Well, Dr. Prouse probably told you on her program that she had to leave the campus of UCLA to conduct her studies because the university was uncomfortable with people in research labs on campus having sexual activity and orgasms.
Totally. So there are only a handful of places around the world that are doing that kind of research on a regular basis, an incredible basis. So we're a long way from speaking definitively about that.
That's right.
And while at the same time, you spoke earlier about the hope that people receive when they have this medical diagnosis or a disease diagnosis. And then there are places that'll charge you $30,000 a month based on that hope that you have, telling you they're going to cure this disease.
Yeah, well, I don't know if people say they're going to cure, but they certainly say they can help you and they can give you hope. But I think we have to bring this to a human level. All of us go to the doctor when something's wrong, and we want them to tell us what's wrong.
Right.
I mean, that's human, right? This is just something we want, and so to have the kind of pain and fear and shame and threat of all sorts of consequences in front of you, and you walk into an office with somebody who's going to help you understand this sexual behavior, it's enormously relieving to be told you have a disease, and here's exactly what we're going to do. Whether it's a useful or accurate or pertinent to that clients feel relieved when a medical practitioner sitting across from them says, this is the story and we've got an answer.
Yeah. But I've seen this process, and you have too, I'm sure. So there's two things happening there. There's the doctor who probably gets sick of saying, I really don't know what to do with this. And once he starts saying, you're a sex addict, you're a sex addict, you're a sex addict, he gets rewarded or she gets rewarded for for saying that and gets a thriving practice as a result. But two, I've seen that couple experience that relief, and oh, thank God, it's just this. He's got the sex addiction thing, and we're going to go, and we're going to send him
and
to
you've
a
got
place
answers for us. You've got tasks for us to do. You've got a sequence of things to do. You've got people we're going to meet who've done the same thing. This is enormously hopeful for people who are scared and have no idea what's going to happen.
Right. And then 30 days later, 45 days later, he gets out, and what he really has is narcissistic personality disorder. And he has, he's just doing all kinds of things. And that could take years, but a lot of people will say there's nothing you can do about that. And he's just spent a month and a half meditating and going to groups and doing all these things in a really lovely place. But he could be years from being even slightly different, and if ever. And there's such almost another level of hurt for the partner in that situation who's like, what did we just do? What did we just pay all of this money for? He's the same guy. He's actually a little worse. Now he's the same guy, but he has a narrative explaining all of the things that, the reasons why he's doing things, and he's blaming me for stuff. Yeah, and that's been that was eventually what chased me away from that, was just watching that several times.
Well, in our model for treating out of control sexual behavior, we see the out of control sexual behavior as a problem, not a disorder. But that doesn't mean we're not assessing and looking at real diagnosable conditions that might contribute or actually explain why they're feeling sexually out of control. For some of the people, we look at, are they in a situation of they're not safe? There's violence or lack of safety in their home, or you mentioned earlier, another aspect of physical safety that makes sexual behavior possibly feel less regulated and out of control is somebody might be suicidal. That's another form of violence. I approach life that I could eventually just end my life as a treatment plan for the distress in my life. That may impact or impair somebody's motivation to change, or it may regulate their sexual behavior more effectively because they hold out the idea I can just end my life if things get too bad. For some people, have medical conditions. I mean, there's lots of research out there that shows real medical illnesses and conditions that either medications can cause hypersexual behavior, or certain psychiatric medical conditions, Parkinson's disease, other things. These actually have hypersexual disorder things. So you have to look for, are there medical conditions that could explain this? And then we also have to look at medical conditions related to sexual functioning. Might somebody have unaddressed erectile dysfunction or orgasm difficulties, or maybe maybe have a conflict about who they are sexually, and they're alone with this. Men oftentimes are isolated and alone with these problems. They come up with these treatment plans all on their own, and so what looks like out of control sexual behavior actually is some sort of an attempt to address a medical or physical condition related to their sexual lives. It's not a great treatment plan, but if they're trying to do something about it. And many people, as you've alluded to, have mental illnesses. They may, have, you mentioned bipolar disorder. They might have personality disorders. They might have depression, anxiety disorders, ADHD. They might have PTSD. There's so many range of the kinds of mental health issues that could be in the office when they're walking in. Yes, their sexual behavior is out of control, but they might have a not significantly, a well-treated enough anxiety disorder condition. It's just not being treated well enough. Or they've never been diagnosed for depression, and they've been living with kind of, depression their whole life, and it's never really been identified. And the last area we look at is their relationship with drugs and alcohol. A significant number of people who have sexual dysregulation and feel out of control sexually in their lives, they're using substances in a dependent and out of control manner. They may have alcoholism that's so out of control, that there's really no hope for regulating their sexual behavior until they treat their alcoholism. A subset of men who have sex with men it's called chemsex. This is really a term that came out of the United Kingdom, but there's a certain series of drugs, GHB and other kind of club drugs that people use. Men who have sex with men will gather together in large group settings, either in home homes or in sexual venues and use these drugs, have prolonged sexual experiences, sometimes for days at a time. And that's called chemsex. And so some men who have chemsex patterns think that, they have out of control sexual behavior or sex addiction. And that's really this interesting chemsex issue. So, these all have to be looked at before you even begin to think, oh gosh, maybe they have out of control sexual behavior. We gotta figure this out first to make sure we're not jumping to conclusions, or as I like to say, that our field suffers from premature evaluation, and there's help for
that. Yeah, that's really well put. It is a premature evaluation, and when you're kind of looking for the thing that we've been talking about this whole time, then a lot of that gets missed.
Well, I think the idea you're talking about, and there's research for this, this is a real human behavior. You're talking about confirmation bias. Confirmation bias is when somebody has a particular idea of something and how they understand things to be, or they need to see or want to see a particular way, that the human brain will do this. They'll filter out information that contradicts the idea they think explains the situation. This is true this is just a human behavior.
Yeah.
And so the OCSB model, as Michael and I describe it, when you have a sexual behavior that is so little understood, there's no consensus about what exactly the nature of this is, how to best treat it. It's something we know very little about. The mental health field has a terrible track record of doing well in those situations. They've thought they understood something, only to 20 years later have to say, no, that's not the case. We were wrong. So the OCSB model is based on the ethical principle of protecting the client as best we can from us. That we need to be trying to not, prematurely place ideas or narratives within a client's situation of having out of control sexual behavior in a way that doesn't really slowly and carefully help the client understand their situation and their individual situation, without applying a broad brush generalization to their situation that may actually be inaccurate and could actually be even harmful.
And that's so important when we're dealing with sex.
Yes.
And there's such a tendency to stigmatize, as you've mentioned earlier, stigmatize sex in so many different aspects of culture and life and society, and down to governmental policy, that if you tell somebody they have a thing, their sexuality may never recover or may be really detrimentally affected for decades.
Yes. These ideas of a diagnostic, kind of label for one's sexual behavior, sexual activity, it needs to be thought of very carefully. So if at some point the science actually does come through and we have a consensus, yep, there is a disorder, there is a disease of some factor of out of control, or what we're going to call dysregulated sexual behavior, there actually comes a diagnosis, great. There's still going to be many people who do not meet that diagnostic threshold who are going to have problems with feeling out of control. Not everybody who has that is going to have the disease. So our model can still help the people who don't cross that diagnostic threshold, this sexual health model can be quite useful for them, even if a disease gets established.
Let's shift over to the second kind of client that you said would come into the practice a lot, the one who's really struggling with his relationship to imagery.
Yes, sexual imagery, yes.
Sexual imagery. And some people might call that a porn addiction.
Actually, 99% of the people, 99.9% of the people in the world call that porn. Okay. Our sexual health languages, we use the word sexual imagery. We describe what the media is without trying to use a pejorative or a judgmental language. Pornography is not, it really has a pejorative history to it, a judgment.
Yeah. So tell me about working with this population. So when they're coming for treatment, is it more often that it's somebody who's just worried about his relationship to it while he's not in a relationship, or was it most of your clients actually their partner was taking issue with what they were doing, or is it a little bit of both?
I think there's three circumstances that come to mind. One is somebody has recently lost a relationship that they held dear. There's been a real loss. As a reason, and in their understanding, that relationship ended. They lost that relationship, having something to do with their masturbation life and sexual imagery, whatever it may have been. Some people are single, not in a current relationship, and they're concerned that their relationship with sexual imagery is so out of control or is so worrisome to them that they believe it's actually interfering with finding love. And that they believe that they're actually going to not find love in their life. They're not going to find a partner. They're dooming themselves because of their relationship with sexual imagery. Some people are very concerned about that. And then other people are very concerned about the secretive sexual life they have with imagery within their partnered relationship. It's either been discovered or it's been discovered many times and they've made promises and there's, to change, and those changes haven't happened. Those are the three most common relationships with sexual imagery. Some people come in, and their conflict with sexual imagery, they could be in any of those situations, single, partnered, whatever. And they're very disturbed about the images they're looking at. It's like, I can't believe this turns me on. Oh my God. They're just mortified, or they're thrilled that it turns them on. They love it. And somebody else hates them because it turns them on, or is disgusted by them because it turns them on, or, thinks they're perverted. I hate to use that word, but that's an allegation that'll be used. Those are big deals. And they all come in and say, I have a sex addiction.
Right.
They all say that.
Yeah. Which is, do you have just recordings that you refer that you must have gotten sick of having to explain that over and over?
No, I don't get sick of explaining it because I don't want to take this away from people. Their use of the word sex addiction, first of all, that's what the culture has given them. That is the language they know. And then quite frankly, that phrase might be what gives them hope. It doesn't bother me that a client uses that language as part of their early relationship formation with me. They're just not going to hear me say it. It's really important. You don't want to take hope away from people. And certain words and certain titles. So, I think there's an interesting kind of responsibility of, even if you don't think that language is accurate, because this is a human behavior we know so little about, I can't just say absolutely that's not true, that doesn't exist. They could walk right down the street and meet another professional who says, right on, that's exactly what you have. So, sure. I can't just hold, with other diseases, we have agreement to what they are. And so if somebody uses the word and it's inaccurate, they could probably go to 10 other people and they'd all say the same thing. It's not an accurate word. So we have to be careful with this languaging of this in our offices, of letting people come at their own pace, at coming to terms with, when they're exposed and learn about the sexual health model, how they eventually might possibly begin to think about different language. I don't think it's an emergency because somebody uses that word in my office.
Yeah, no, definitely not. We've kind of started to wander into this area at a couple different points. This is a podcast about erectile issues.
Yes.
So let's just segue from what you were just talking about there, of those three typical kinds of presentations. You didn't mention the guy who comes in because all the sexual imagery that he was taking in had led to an erectile malfunctioning.
It happens.
Okay.
In other words, what I mean by it happens is people say this is their story. That's what happens.
Okay.
Again, this is premature evaluation. Somebody is having difficulty with their erectile functioning, and they have come to the conclusion that it's correlated or completely linked with the fact of their relationship with sexual imagery and their masturbation practices. The science is beginning to reveal there's many explanations for this. One of the least likely explanations is that they have a biophysiological erectile dysfunction that can be measured. I did have a couple of clients, however, who came in and said I was a porn addict. And what the situation was is they actually had low blood flow to their penis, which was a biological condition from birth. And they had adapted to looking at sexual imagery as a way to as their own kind of erectile therapy, thinking that if they masturbated, they could, gauge their penile tumescence, or they could gain confidence in how they could have orgasms while masturbating, so they might have more confidence during partnered sex. All of this, but they began to somehow think that their erectile difficulty was because of watching sexual imagery, when actually their use of sexual imagery was at such high frequency because they had an existing erectile dysfunction that was biophysiologically caused, right? Yeah. So the imagery had nothing to do with it. Yeah. So there's a lot of thinking errors here. Another a porn addiction kind of narrative will be that somebody has a very unconventional turn on. And the only way they see this can turn on is through going to imagery online. Let's say they like somebody being tied up and being restrained, and they imagine they're the person being restrained when they're watching this, and that fantasy state is very highly arousing for them. And they learn that this is actually their most preferred way to have highly pleasurable, sexual fantasy and arousal and body sensations that gives them the most pleasurable orgasms. And then they're in the middle of partnered sex, and this fantasy isn't accessible to them. They can't have the body experience of restraint because they're in the middle of having partnered sexual activity. And so they've learned this is such an important arousal, and it's a secret to their partner, by the way. Mm-hmm. And all of these things are inhibitors that get in the way of sexual excitement. And so these inhibitors are now interfering with their ability to be excited. And so they're not sexually functioning as well. And the client will make the connection, oh, this is because I'm looking at imagery, when actually they have a conflict about what turns them on. Where do men learn how to say, I have an erotic conflict? Where do men learn to say, there's something that turns me on that I feel so ashamed of, and if I think about it while I'm in the middle of partnered sex, I feel ashamed of it because I'm not present with my partner, and then I lose my erection, and then my partner knows I just masturbated 2 days ago, and so it's, well, it's because you're masturbating too much. And that's the story in the couple, because the erotic interest can't be discussed. It's too shameful, it's too painful. So the porn addiction is the better story, because then you don't have to disclose your erotic conflict.
Right. No, I love that. Where do men learn that they have an erotic conflict? Where do they learn to say it?
That's right. Where do they learn to say it? And I can tell you, in this is one of the criticisms I have of many of the treatment approaches, not just sex addiction. Many of the treatment approaches for this behavior don't have really thorough and really slow, methodical ways of helping men begin to identify an erotic conflict that they have, without that erotic interest being seen as something wrong with them. As I like to say to the men we work with, no erotic ectomies here. We're not going to remove what erotically arouses you. That is not the point of this therapy. We're going to try to help you enjoy that erotic arousal as much as it's designed for pleasure for you, and keep your relationship agreements, and not violate basic fundamental ideas of sexual health. There's a way to do that.
Okay. So what about, I think one of the more common tropes though is, so the competition, right? So guys in 15-year marriage, 2 kids, and now he's watching a couple hours of porn a night after his wife goes to sleep, and he's watching college gangbangs, and his wife is not 30 college students every night, right? And that comparison, and I think our culture says, well, like, she can't compete with that. He's desensitizing himself to being able to be turned on, and she'll never be able to turn him on again.
Well, there's about 5 different sexual narratives in that one situation that could all be part of it. Right. But the easiest story is all of the problems this couple is having in their sexual life is because he looks at this imagery. That's the dilemma with that story. There's so many possibilities there. The biggest word that comes to my mind in that story is avoidance. This is a couple who, for for all sorts of reasons, they're busy raising kids. I mean, who knows? There's so many things going on. I don't know what all the circumstances are, but I know that one of the most common approaches to sexual concerns in couples is they avoid them. They don't. Who teaches couples how to talk about their sexual lives with each other? I mean, I ask people when they come in, what's your masturbation agreement in your relationship? And it's like, what the, they don't even know what that is. It's like, what do you mean? We don't even know if each other, they don't even know if each other masturbates, no less what their agreement is on it, right? So the dilemma with all of these avoided problems in couples around their sexual lives is they get avoided until somebody's hurt. And that's the dilemma. The injury carries too much weight for understanding the big problem. This couple you just described, that's a 10-year arc, 15-year, I don't know what it is, but there's a whole lot of things that could have contributed to the situation they find themselves in. The sexual imagery is the easiest target. Esther Perel, in her book, The State of Affairs and Mating in Captivity, both, talks about when couples lose desire for each other and the erotic vitality of couples. There's a lot of reasons why erotic vitality can be lost in couples. And then sometimes the masturbation life is the way a person is keeping alive their erotic self, because there's no other place for it to be on life support. Now, are we going to call that a disease? Or are we going to call that life-saving techniques? It's all about perspective.
Yeah, no, it really is. It really is.
But notice how what I'm saying is this is hard work. This is difficult work to explore and figure out why this couple is in this situation. Whereas the porn addiction story creates a ready-made narrative that doesn't require the kind of in-depth, individualized, painful exploration of two people looking at each other and trying to figure out how we got here.
And that's very daunting for
it
a lot of people.
So, give me porn addiction. All right, here we go.
Yeah. Go and stop watching this for 30 days. Join the no fap movement.
Yeah.
How do you feel about those guys? The no fappers and the this is your brain on porn and all these.
You got to remember, there are these sorts of ideas about sex thrive in every culture. Where eliminating certain sexual behavior is the solution to complicated conditions and situations. What draws somebody to those particular interventions? What draws somebody to go to a site where you learn how to stop masturbating? The motives for that can be very many and very wide. I want to remind viewers that there was a time in our country when people who had same-sex attractions, the mental health field provided therapy that said we could make that go away. And people came to those therapy services in droves. We live in a culture that as long as somebody offers a viable solution to sever an erotic interest, there'll always be a commodity of people who find that very appealing. So I don't begrudge those resources. They've always been there. The mental health field, for crying out loud, licensed mental health professionals in this country 40 years ago were pretty much offering the same thing. So who are we to cast stones? It's just that there'll always be a group of people who want this solution.
Yeah. Who the first thing they want to point to is it's the sex.
And in a Puritan culture, which we are, it comes from our very origins. that, in our culture, being uncomfortable with sex is a very powerful position to be in. When you're comfortable with sex, you don't have power in our culture. The people who have the power, who are walk in the room and say, that makes me uncomfortable, stop it. They have the power. People adjust to the people who are uncomfortable about sex. And this happens in families and couples. If one person in a couple says, that's disgusting, that makes me uncomfortable, I don't want that, they assume the rest of the system will adjust to them because their discomfort should be the power. Their disgust should hold forth.
Right. And we're pushing back on that a little.
Well, that's the ebb and flow, right? That's the ebb and flow. And it's always been in all cultures and over history. We can go back through history and see there were times this tension always exists, and it ebbs and flows. It ebbs and flows in couples, it ebbs and flows in cultures, it ebbs and flows in families, it ebbs and flows over time. And so we just have to kind of put this into perspective.
I don't know if it's just because of the world that I'm in and being around sex therapists and on, seeing your emails and a ASEC listserv and things like that. But I do feel like we're in a bit of a sexual explosion right now.
I think for me, the number one impact on the sexual lives of everybody on the planet is the internet available by a cell phone. These are sexual toys that we get to walk around with in our pocket 24/7. The access to talking about sex in privacy with other people, the access to seeing sexual imagery and sexual activity is literally never before, unprecedented in the history of humankind. And so, I like to remind people that when the automobile was invented, we didn't realize we had to teach people how to drive automobiles and give them licenses until the automobile had been around 30 years and people were dying in car accidents everywhere. Somebody figured out, well, maybe we better issue driver's licenses. So we have to respect that the internet and the access to these kinds of sexual imagery is very new for people to understand. And so we don't have cultural norms. We don't have, as established ways of relating to this as far as sexual imagery. And so we got to be careful to call people who don't know how to use this as well as the ones with the problem. There's a time of an adjustment. It takes a huge amount of adjustment for these kinds of changes that only happen every now and then in the course of history. And we're in one of them right now.
Yeah. Now I love that analogy. We have to teach people to drive. I actually recently did some work with Pornhub, and I feel very strongly about that, because they have such a presence that at some level we're going to have to take a real strong look at, putting out sex positive instructional porn that might be seen by a lot of people that, are watching porn and accessing porn otherwise.
Well, there's a movement that's just beginning to even be able to be spoken, just to even to be said, and it's called porn literacy, and that's the phrase that is being used in the sex field. Because it's a way for people to understand what they're talking about. So you have to say the word porn, just like you have to say the word sex addiction, so people know what we're talking about. So porn literacy, just like driver's license, it takes a while for people to understand that this is actually not a restriction on liberty. This is not a restraint of expression. That this is actually a responsible thing to do with something that has major consequences when you don't have literacy on how to use it.
Right. If we don't offer porn literacy courses, it would be like, well, let's put somebody in a car without taking drivers.
Exactly. And we did that for 30 years, by the way. So it's not like we did not have driver's licenses for 30 years after the car was invented. The first driver's license was issued in Pennsylvania in the late 1920s.
God.
Right? So cars were around for almost 30 years. So human behavior, this is what human behavior is like. We have to go back to history and get comforted by looking at history that this is just another another cycle of the same human response to significant change. We didn't call people who got into car accidents diseased.
Yeah.
You've got a mental illness. You got into 3 car accidents in the last 5 years. And this was 1920.
Well, that's a hopeful point. That was one of the last things I wanted to talk about. Was I didn't mean for me or us to, by challenging the sex addiction model to say that this is hopeless. And I was hoping that you could close with, because you've worked with addiction, you've worked with in alcohol treatment and drug treatment, and where there would be sexual acting out in conjunction.
Okay, now can you say that differently than sexual? I'm going to challenge you, Tim. Tell me what you're saying.
I would be saying there would be the sexual breaking of agreements, and there would be erotic conflicts that happened while in conjunction with taking more drugs and alcohol than they had wanted to.
Yes, that's right.
To a point. No, and I am a big fan of looking at language, and I appreciate the correction.
So what was your question? Because I interrupted you because you said acting out.
So the hope for the OCSB client who actually does reach that diagnosis, who might be in, and also struggling with just impulsivity or out of control behavior in life. Like, what is the hope?
I think the first thing is you need to figure out who you want to talk to about it. If there's something you've heard me say here on this podcast that sort of excites you and interests you, see if you can find a therapist who works with sexual dysregulation. That's the general term I use. From an from a sexual health perspective, sees it as a problem, might consider it as an out of control sexual behavior, not a disease or disorder. If that's important to you, if that seems like a source of hope for you, there are people that you can find perhaps in your region. There are not as many of them, but you might find some people who are at least willing to work or learn or have been trained in this method. If you've listened to this podcast and I sound like a quack, and that this is dangerous talk, and that you're gonna endanger people's lives by not calling them a sex addict, that you're a fool, then you need to call a sex addiction therapist, because that's where you're going to find hope. And as you said, sometimes you'll find people who started at the sex addiction stage and found themselves in your office because for whatever reason, the hope wasn't there for them anymore in the sex addiction model. But who knows? Maybe they needed to start there to get where they are now. I don't know. But I'm more interested in empowering clients, empowering people to walk in a door where they think they're going to find hope. And the problem was there was only one door primarily, and that was sex addiction. And I'm just interested in offering more doors. And ours is a sexual health door.
And you could say with confidence to that person who comes in and says, I'm worried I'm never going to have they'll say healthy. I'm never going to have a healthy or a normal sex life ever again. And you could say what to them?
Why did you come up with that idea? Is what I'd say to them. How did you decide this? Where did you come up with that idea? This is their idea. And I'd help them figure out where it came from. I'm not going to give them some glib answer that soothes their fear. I don't know enough about them. Maybe that's an accurate assessment. I don't know. I have no idea. I got to get curious.
Yeah. Okay. Very well said. All right, Doug. Well, do you feel like there was anything else that you wanted to cover in this topic?
Well, I guess I just want to say to you, Tim, the conversation we've had today is a little different than the conversations I've had with other people in some of the media work I've done because of your experience. I just want to applaud you for having had your feet in several pools of sexual behavior concerns And that's, I just want to applaud you for that journey, because that's not an easy journey for clinicians to do. And
Thank you.
I'm just heartened to talk to you, and the questions you've asked show me that you have a lot of experience in this area. You really, I talked to other media people, and they conceptually understand these ideas, but it shows in your questions that you've sat in the rooms with these various ways of working with this population, and it made for a richer conversation. So thank you for that.
Oh, absolutely. I really appreciate that. This is what we love. This is what we do. And this is what you have loved and done. This is a big changing year for you. So you're still going to work, but you're just going to focus on training.
Training, teaching, and writing.
Okay.
Yes.
Training, teaching, and writing.
Yes.
Okay.
And my clients know, clients know about this decision. My clients know my motivation for this decision. And so I can say this to you on this program, and it's not anything I haven't also said to the people who I'm saying goodbye to.
Well, I can tell from your eloquence and insight and experience that you're a wonderful trainer, and I'm really glad that you're going to continue to do this work.
Thank you.
Where can people find you on the internet?
At the website for the company my husband and I co-founded in 2013, called The Harvey Institute. It starts with theharveyinstitute.com, and that you'll find all the information about the services of education, training, consulting, and all of the books, the 3 books that I've written, journal articles, media, interviews, a variety of resources, and in full information about the sexual health model here that we've spoken about today.
Okay. Well, fantastic. Well, thanks so much for this, Doug. This was wonderful. When we spoke originally, I think we could tell like this would be a good conversation, and I'm glad that we're offering that perspective out for other people. And thank you so much for your work and your words.
Thanks, Tim. It was great to be here.
And your attention to words.
You were a good sport. Thank you. Bye-bye.
Take care. Thanks to the show's executive producer, Robin Morrison. Thanks to Kat Murphy, director of social media. Thanks to Team Scrub for the music. Thanks to the sound engineer, Ravi Carmen. Thanks to Brian Hui for naming the show. Thanks to Alex Pitts for the intro. Thanks to Arlene Asuncion for the logo. You can find this podcast at hardconversationspodcast.com or wherever you get your podcasts. You can locate me on Twitter at TimNortonLCSW. or on my website for my private practice, timnortontherapy.com. You can also email us at hardconversationspodcast@gmail.com or call into our hotline at 662-626-4276. That's 662-MAN-HARD. Thanks to all my friends and family for brainstorming this show with me. Shout outs to the sex positive community, including sex educators, sex therapists, sex coaches, other fellow sex podcasters, sex surrogates, academics, the sexual health medical community, sex workers, the tantric community, and everybody else involved with having hard conversations. Bye-bye.